If we can see further, it's because we stand on the rungs of a ladder built by those who came before us. I'm Jim Wolfe, and I'm inviting you to share with me a short camcast in which I'll offer some personal history of MCH starting right at about the time that I was born. Not that I remember that part of it. So come with me and take a tour through recent history of MCH on this IH87 introductory camcast. I was born in 1947, shortly before the formulation of the definition of health by WHO, which occurred in 1948. That effort was led by Andreas Stamp, an outspoken Croatian physician who founded the School of Public Health in Zagreb in 1927 with a grant from the Rockefeller Foundation. 25 years later, as a medical student, I received an AAMC fellowship to study at the Stampar School of Public Health in Zagreb for 6 months and learned even more about Andreas Stamp and his amazing career in public health. From the base at the Public Health School in Zagreb, Dr. Stamp began to develop the public health system for the whole of Yugoslavia. As a result of these successful activities, he was invited by the King to take up a cabinet post of Minister of the Interior. Dr. Stamp accepted the position under certain conditions, which the King did not accept, and subsequently he moved to China as an official of the League of Nations, a forerunner of the United Nations, and set up a fledgling public health system there under its auspices. During the Second World War, he spent some time in prison, but in 1945 he was appointed professor of social medicine in Zagreb. And in 1946, as president of the Interim Committee at WHO and chair of the first WHO General Health Assembly in 1948, he introduced the famous definition of health that is still being used today. And that definition, of course, is health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. I was a junior in college when Dr. Maurice King published Medical Care in Developing Countries. The book was a classic primer on the medicine of poverty and has influenced a generation of healthcare providers working in the developing world. This classic book evolved out of a WHO UNICEF-sponsored conference on health centers and hospitals in Africa. In it, Dr. King, David Morley, who we'll talk about in the next slide, and Derek Jelliff and others came together under King's editorship to create a remarkable, comprehensive handbook for medical personnel. The slant is decidedly toward the doctor and other professionals from the developed world who are working in the developing world. The material covered ranged from organization of health services and a cross-cultural outlook in medicine and pediatrics, anesthetics, and work in the laboratory. The recommendations in this book are realistic and acknowledge the limits imposed by poverty and lack of resources. In 1973, when David Morley published Pediatric Priorities in the Developing World, I was finishing up my first year of medical school. I didn't know it then, but I was to carry David Morley's yellow-orange book with me for the next 10 years as my pediatric Bible. David Morley was a British physician who spent a good part of his career in Embassy in western Nigeria doing what was relatively a new concept at the time, developing an evidence base for the delivery of health services to mothers and children. Afterwards, he returned to London to establish the Institute of Tropical Child Health at the University of London School of Tropical Medicine and Hygiene. At that time, in 1973, the average per capita healthcare spending in Africa was $1 versus $100 in Europe. And there were 20 million deaths in the developing world. That number, of course, has been drastically reduced since that time. David Morley believed in the principles underlying the provision of health services, the social, economic, cultural, ethical, and political factors that influence health and disease were not part of the definition of medical, and consequently, they weren't taught in medical schools. The result of that was that physicians trained in the West and working in places like Nigeria and other developing countries were unprepared to be effective providers of healthcare services. One of his first exercises was to establish priorities among health interventions that took into account the economic, social, and political constraints. This actually made him a pioneer in public health for mothers and children. In his book, Pediatric Priorities in the Developing World, that I carried around as my little Bible when I first went to work overseas, he highlighted several key issues. First, Western developed country orientation and training of physicians and nurses was not appropriate training to work in the developing world. Second, nutrition and infectious disease were key factors in health and disease and needed to be addressed. Third, the predominant location of patients was rural, yet 3/4 of all medical spending was urban, and 3/4 of physicians lived in cities. He also noted that to be effective, services needed to be provided in every section of the community and near the child's home. That it was very useful to keep the mother and children together as a unit, and finally, that it was absolutely essential to get senior pediatricians and senior health administrators involved in organizing the health services at the village level. In 1978 was the year that I finished my pediatric residency and returned to Boston on an NIH fellowship in tropical public health. It also was the year of the Alma Ata Conference in primary health care in Kazakhstan. This conference brought 134 countries together and 67 international organizations to create a strategy for reaching the goal for health for all in 2000. Primary health care was defined as the essential health care based on practical, scientifically sound, and socially acceptable methods and technology made universally accessible to individuals and families in the community through their full participation and at a cost that the community and country can afford to maintain at every stage of their development in the spirit of self-reliance and self-determination. PHC was a movement inspired by the ideals of democracy and social and economic justice, and promised expanded coverage and increased access to health services to populations marginalized by geography and poverty. It was a strategy that was fundamentally aimed at providing greater coverage and greater equity. I, of course, was passionate about Alma Ata and about the possibility of creating a health system that addressed the multiple factors that David Morley had identified as critical to improving health. Alma Ata led to a focus on health system delivery that was system-wide and is often referred to as horizontal. We've come back around to this way of thinking recently with our focus on capacity building, our emphasis on IMNCI, integrated management of neonatal and childhood illness, and sector-wide strategies. But in 1978, this mode of thinking didn't last very long. Time to pause this camcast, and we'll pick up again in a minute with part 2 as we move to 1979 and explore selective primary health care. See you in a minute.